Welcome to everybody who's watching. My name is Dr. Gemma Clooney, and I'm excited to be here sharing this session on voice and VCT. We've got a really fascinating range of presentations from, well, 4 brilliant speakers, really kind of encapsulating the full breadth and range, I think, of SLT involvement in a voice caseload. So I'm very excited to get started. And we're going to start with Dr. Rujan Vermeulen, who is joining us from South Africa. And she's going to be talking to us about the outcomes of voice use reduction program on the voice quality and vocal fatigue of occupational voice users. Can I ask people to put questions in the Q&A box, and then we'll have some time at the end for some discussion. Over to you, Rujan.
Thank you so much. So, good morning, colleagues. As she has stated, my name is Dr. Rujan Vermeulen. And today I'll be presenting on an article I recently wrote in the compilation of my PhD thesis at the University of Pretoria in South Africa, exploring the outcomes of the voice use reduction program on vocal quality and vocal fatigue in occupational voice users. So before I jump right into it, I just want to see if my slides will go on. Can I ask for the next slide? Because it seems like I can't control my slides from my side. I don't know why. Let me see if I am doing this incorrectly. Okay, there we go. So before we jump right into it, I'd firstly like to name and acknowledge my co-authors and their affiliations who put this paper together with me. I think all of you who are involved in active research know just how important these people are at the end of the day. Getting scientific papers to completion and publication generally requires some support. So Dr. Maria de Toy, Prof. Marine Alet Graham, Prof. Jeannie van der Linde, as they are all associated with the Department of Speech, Language Pathology and Audiology at the University of Pretoria here in South Africa, as well as my international collaborator, Professor Christiane van Lierde, affiliated with the University of Ghent, Belgium. So from here, let me attempt to break down the rationale of the study to easily digestible and hopefully understandable chunks for you. The aim was to determine the outcomes of the voice use reduction program, or hereafter referred to as the VUR program, a first conceptualized idea by Anita van der Merwe in 2004 on voice quality and vocal fatigue in occupational voice users, or hereafter referred to as OVUs. So OVUs' livelihoods depend partially or completely on their voice. However, the prevalence of voice disorders in this population is rising due to increased daily vocal demands. As a result, voice management and vocal health of the OVU have received renewed attention, although expectations placed on different OVUs pertaining to vocal load, voice quality, vocal sophistication may differ. All OVUs depend on vocal stability and endurance at the end of the day. Research reveals that vocal fatigue symptoms have a detrimental impact on the economic and vocational goals of OVUs, consequently also affecting their psychological well-being and quality of life. And naturally, one's ability to communicate effectively has a significant influence on the workplace. Literature suggests that when voice problems arise, employees exhibit reduced productivity, reduced work quality, restriction of occupational activities, and increased absenteeism. Employers note increased costs for substitute workers, employee turnover, medical treatment, and workers' compensation claims due to persisting voice disorders. As a result, in the efforts to prevent voice disorders in OVUs, the implementation of vocal hygiene education, or VHE, programs have been endorsed. So this is the problem we are faced with. Now, how do we intend to counter it as speech-language therapists? In this study, we wanted to explore whether relative or modified voice rest could be applied to assist OVUs in voice management. VUR, voice conservation, relative or modified voice rest are all terms we find in the literature, but all refer to a similar concept of reducing voice use, but not complete or total voice rest. This practice is viewed as central to VHE programs and can be used as a method to adapt daily routines aimed at directly enhancing vocal health. Despite the common recommendation for voice rest, a consensus regarding the specifics of the implementation of the type and duration of voice rest varies among clinicians. The recommendation of absolute voice rest or complete silence has become controversial over the decades, as more recent studies suggest that benefits from these practices are questionable and may even lead to negative psychological effects on the client and deconditioning of the vocal apparatus as a finely tuned occupational tool. A prospective randomized study comparing voice rest after phonosurgery, classified as either relative or absolute, identified that relative vocal rest resulted in increased improvement in vocal stamina, long-term recovery when compared to absolute voice rest. Thus, complete or absolute voice rest of more than 3 days is presently limited to medical diagnoses of severe acute laryngitis, laryngeal trauma, and as post-operative laryngeal surgery guidelines. In contrast to this, VUR practices remain popular and are commonly recommended for anywhere between a few days to months, depending on the severity and expected outcomes. A previous study suggested short-term relative voice rest, followed by 1 to 4 weeks of gradual introduction of the voice for acute overuse. This is very similar to the VUR program, as it gradually increases voice use in stages until the voice has fully recovered. So the intention of the study was ultimately to introduce a method to adapt daily routines by directly enhancing vocal health through the VUR program. Although this formalized approach has been available since 2004, the effect was yet to be determined. Thus, the VUR program was tested as a simple, accurate, and sustainable vocal hygiene solution to individualized management of daily voice use in the OVU. So, to give you a picture of what the VUR program is in a nutshell, it is a structured behavioral modification approach to VUR. And currently, it is the only program that utilizes a controlled period of reduced daily voice use in order to enhance vocal health and quality, reduce vocal fatigue, and improve vocal fold pathology and appearance. VUR is permitted by allowing, monitoring, and closely calculating the maximum units of voice use per day and per week in severe, moderate, and low VUR stages. It is suggested that VUR may facilitate the process of tissue repair and precipitate regeneration of vocal fold epithelial cells due to essentially allowing the vocal fold musculature time to rest. I know this only gives you a very quick overview of the VUR program, but please feel free to go and look at it in detail in Van 2004 article and see how to use it step by step. The article really explains it in the nitty-gritty, and I don't have that much time with you this morning. So let's quickly look at my methodology as well. A within-subject, quasi-experimental, pre-test, post-test research design was employed in which a total number of 30 male and female adult OVUs were invited to participate. The various professionals were call center agents, teachers, lecturers, singers, and performing artists. Initially, the case history questionnaire was completed, and then for pre-post-test assessments, they completed the vocal fatigue index for comparison of self-perceived vocal fatigue, as well as the acoustic and perceptual measurements implemented, being the maximum phonation time, the SZ ratios, the multidimensional voice program analysis, voice range profile, dysphonia severity index, and the Gurk-Basi 4-point rating scale was used. Participants were asked to use the VUR program daily for 8 weeks. All of the participants' problematic vocal behaviors were identified and specified in quantitative terms, and quantifiable goals were set. The participants were guided on how to apply the program. Progress, adherence, and implementation were monitored by both the participant and the researcher, myself, weekly by reporting and charting voice units in face-to-face feedback sessions. So here are examples of the charts that I were using throughout my study. Voice use units allocated throughout the stages of VUR. But as I only have so much time with you today, and some of you might want to better understand how to use these charts in practice, or the VUR program as a whole, I again strongly encourage you to go and look at that original article and see how the charting of the voice use units can be done in practice. But let's get on to my results. The perceptual differences between the pre and post-test revealed a statistically significant decrease in grade of hoarseness, roughness, asthenia, strain, and instability. Perceptual normality in all these areas also increased significantly at post-test, indicating significant improvement in the perceptual voice quality overall. Acoustically, a reduction was seen in jitter results in a voice with decreased roughness associated with pathological voice and dysphonia. Enhanced vocal health is also indicated in the reduction seen in intensity minimum, as dysphonic patients were previously found to have increased minimum vocal intensity when compared to healthy voice controls. Overall dysphonia levels amongst participants decreased significantly by the reduction seen in DSI scores, or dysphonia severity index scores, sorry. Increased maximum phonation time indicated participants presented with better glottal control, efficiency, and levels of coordination of breathing and phonation. Higher frequency max and fundamental frequency max indicated that participants were able to reach significantly higher frequencies than before, and therefore presented with larger vocal range after the VUR program. The vocal fatigue index outcomes revealed a significant decrease in tiredness of voice and physical discomfort at post-test. Improvement of symptoms with rest remained unchanged before and after VUR, merely due to the participants consecutively scoring this section high, and reinforces the notion that overuse strongly perceive improvement of symptoms with rest in terms of vocal fatigue, regardless of the current level they are experiencing. Briefly, here are some of the tables. Sorry. Did
You've
someone
got
have a
about
comment?
1 minute. No,
Okay,
it's just you've got
perfect.
1 minute left.
Okay. So briefly, here are some of the tables, but I've already summarized the important aspects for you. So we must take into consideration that occupational voice users are faced with multiple risk factors for vocal pathology and subsequent voice disorders due to prevalent medical, voice use, and emotional characteristics within this population. Most of the participants report suffering from gastroesophageal reflux disorder, and this is important to consider as 50% of patients with voice disorders also normally present with some sort of reflux disorder. And understanding this would greatly improve their subsequent voice treatment outcomes. With regard to emotional characteristics, all the participants reported bodily signs of tension, and almost all the participants reported stressful work or home environments. I want to get to our take-home messages. So what are they? The numerous risk factors overuse face make them vulnerable to altered voice quality and vocal fatigue. When overused are left unable to perform their daily occupational tasks due to voice changes and vocal fatigue, this detrimentally affects their psychological well-being, professional lives, and ultimately their quality of life. The insights gathered in the study have found that the use of VUR significantly reduces the degree of voice disorder and dysphonia. The noteworthy enhancement of vocal quality, possibly due to improved condition and health of the vocal folds, is evident in acoustic and perceptual results. As previously mentioned, the VUR program decreases levels of stressed emotional state overuse experience, thus assisting prevention and treatment of voice disorders on a multidimensional and holistic level, as proposed by the ICF framework, positively impacting the overuse overall quality of life So when approaching overuse, clinicians are encouraged to make use of a combination of direct voice therapy, of course, and vocal hygiene, accompanied by a sustainable program such as the VUR to help develop further healthier use of voice, foster patient autonomy, facilitate healing, and prevent further and future injury. Voice rest has been proposed to decondition the voice, where voice therapy is thought to recondition the voice and therefore should be used congruently. These findings serve to promote vocal health consciousness and awareness for preventative voice care initiatives in this unique population. Hopefully, findings can inform authors writing standard protocols for governing associations and guide practice guidelines, and practitioners globally, as well as academic leaders compiling curricula for future undergraduate training of speech-language therapists and other voice care professionals in the inclusion of voice use reduction in clinical voice care initiatives. Thank you so much for listening.
Thank you. And our next speaker is Jo Levitt, who is an independent researcher and is going to be talking to us about vocal health in choirs. If you want to share your slides.
Thank you.
And just a reminder to put your questions in the Q&A box.
Okay, just checking you can see my presentation.
Yeah.
Great. So, good morning. Amateur choir singers. Does good vocal health matter? My name is Jo Levitt. I'm a paediatric speech and language therapist based in Kent. And Dr. Tim Pring and I recently collaborated on this research, which was published in the IJLCD this year. So why research amateur singers' vocal health? Well, singing really is good for you. Studies show that it has the potential to benefit physical and mental health and to reduce social isolation. Professional singers go through many years of training and they are acutely aware of their vocal health and will seek help if they have problems with their voices. After all, their livelihoods depend on being able to sing. Amateur singers, however, are potentially less aware of the hazards of poor vocal health and voice disorders and may lack healthy singing techniques. When I looked into this, the existing research into vocal health mainly looked at professional singers, understandably, but I was particularly interested to look at amateur singers, so that's why this is based on amateur singers. So what were my aims? As somebody who has sung in amateur choirs all my life, I was very interested to assess the experiences of amateur choir singers, particularly in relation to their vocal health. To look at their use of vocal warm-ups and cool-downs. In other words, whether they did them at all, whether they were done at choir practice or individually, and actually whether they made a difference. I was interested to find out about their vocal health, where they turned for help and advice if and when they experienced problems with their voices, and how they felt about receiving a diagnosis of and treatment for a voice disorder. We used a mixed methods approach. A SurveyMonkey questionnaire was sent out via email and social media. Snowball sampling occurred and we received a whopping 852 questionnaires, which actually I think shows a real interest in the subject. We discounted surveys from singers who did not sing regularly or who were under 18 or who sang in a professional capacity, thereby leaving 764 usable surveys. Quantitative data was collected on amateur singers' use of vocal warm-ups and cool-downs. I also asked singers to rate how frequently they experienced 5 adverse voice symptoms after singing, and these vocal symptoms were frequent throat clearing, vocal fatigue, loss of range, hoarseness, and pitch breaks. Qualitative data was also collected from singers who had sought advice about their voice and from those who had received a diagnosis and treatment. Open-ended questions were asked about singers' experience of voice symptoms, what help they had sought, and for those diagnosed with a voice disorder, what therapies were recommended and whether they were beneficial. So, what did we find? The quantitative data showed that many amateur choirs do warm-ups before singing. In other words, the warm-ups happen at choir practice, they're led by the musical director or conductor. 51% of our singers did a vocal warm-up at choir only. And those vocal warm-ups at choir practice consisted of things like singing scales, humming scales, breathing exercises, stretches, lip drills, singing through a straw, that's your semi-occluded vocal tract exercises, and others. And if anybody needs an explanation or even a possible demonstration of those, let me know. Most choirs used several exercises and singing scales was the most frequent. We also found that most choirs do not do cool downs after singing. When we analysed the symptom scores of singers with and without choir warm-ups, we found this to be highly significant. Singers who did the choir warm-ups experienced significantly fewer of these 5 vocal symptoms. We also found that individual warm-ups were largely ineffective. I was really surprised at this at first, but when I did a bit of a deeper dig into the data, I concluded that perhaps they were doing ineffective warm-ups. They were doing things like singing along to a CD on the way to choir, which is possibly not an effective warm-up. So remember that singers were asked to score themselves as to whether they experienced those 5 adverse voice symptoms after singing. Now, looking at those with high symptom scores, we found that singers who had previously had a diagnosis continued to have significantly higher symptom scores. I mean, this is probably not surprising. After all, we don't know when they got their diagnosis, but what we do know is that they're continuing to sing despite their diagnosis. But rather worryingly, a quarter of the singers who had neither sought help nor had a diagnosis also had high symptom scores, suggesting they may unknowingly have a voice disorder. Our qualitative data showed that singers appeared uncertain as to who to consult for help. They spoke to various professionals such as singing teachers, GPs, ENT, and speech and language therapists. But those who were seen by speech and language therapists were actually much more likely to receive a diagnosis and treatment, either by the SLT themselves or by referral to ENT. We also found that those receiving treatment were mainly positive about it and likely to complete a course of therapy. So, what are the implications of this? The first and most striking implication has to be around those choir-led warm-ups. Our analysis strongly indicates that choir warm-ups are helpful in avoiding voice symptoms and therefore are definitely recommended. This didn't surprise me, but it was really nice to have some strong evidence to back it up. Secondly, the presence of singers who are unaware of potential damage to their voices is a concern. Remember that a quarter of those with high symptom scores had not sought help nor received a diagnosis. In our analysis, we used a simple vocal health rating system like this one. We asked singers to rate how often they experienced each of these 5 symptoms after choir singing, and we then scored their responses with 0 if they said never, 1 for sometimes, and 2 for often. So with the 5 vocal symptoms, that gave each singer a potential score out of 10. Now, our analysis suggests that a score of 4 or more in the total box at the bottom is a possible cause of concern and perhaps a likely indication of a voice disorder. What we're suggesting is that choirs could adopt this very simple system for potentially screening the vocal health of their members. And so, to summarise, our analysis suggests that in order to protect the vocal health of amateur choir members, choir leaders should carry out effective warm-ups, be more active in advising singers, and refer them to professionals where necessary. And one final thought. Our analysis also found that speech and language therapists appear more sensitive than other professionals to amateur singers' voice problems. And so we feel that they might be an appropriate first point of contact. Thank you.
Thank you so much, Jo. So our final presentation is from Alicia Porter and Dr. Sean Pert, and they will be talking to us about the objective evaluation of voice with trans and non-binary people.
Thank you very much. My name is Sean Pert. My pronouns are he, him.
And I'm Alicia Porter. My pronouns are she, her.
And we're going to talk about how we've incorporated what could potentially be a quite complicated tool into our clinical practice, but we've been quite surprised at how positive our service users have been about the data that we've been able to share with them.
So the pie chart that you can see here is just to give you a bit of a quick overview of the gender identity of our service users who have accessed our voice and communication therapy groups. This data is from October last year, October 22, up until October this year. So as you can see, 68% of our service users identify as trans women, 13% identify as trans men, and 19% identify as non-binary. Now, within that 19% of service users who do identify as non-binary, let me double check it, yeah, 13% identify as non-binary and wanting to own to more of a feminine spectrum style of communication, and then 67% identify as non-binary aiming towards a masculine style of presentation. Now, why is this important? Well, it's really important to show that we work with a range of gender identities, and with our voice and communication therapy groups and the computerised voice evaluation that we need to implement, it's not just trans women that we work with as well.
So risk of voice disorder is higher in trans and non-binary people, and although this is not well researched, it's probably because they are either consciously or subconsciously making changes to their vocal performance even before they start to consider voice and communication therapy changes. So you can see here that we've had ENT referrals indicated for 1 trans man and 4 trans women during this period. We've also had questions about the use of chest binders, and we have to balance the risk of people feeling too dysphoric to engage in voice exercises versus the restrictions on things like breathing capacity caused by chest binders.
Fab. So here you can see that we do computerised voice evaluation on a range of recordings. So we use the evidence base to support with these recordings. We do a sustained R. We do a connected speech recording using the rainbow passage, which I'm sure a few of you will be familiar with, and happy birthday, singing that to have a little look at pitch change there as well. So we look at pitch measured in hertz and loudness, sound pressure level measured in decibels. We also do, now what this presentation is focusing on is CPPS, so that stands for Smooth Septal Peak Prominence. Now this looks at the jitter and shimmer of the voice and the vocal quality, and if you want to have a chat about that a little bit further, we do a whole presentation on this, find us and we can have a chat about that after as well. So we use all these recordings with each service user, and we're going to have a little bit more of a chat about that today. But it's really important because this is recommended by ASHA using the CPPS, but it's not yet widely used in practice. And I promise you, it's really easy to do. It looks complicated, but once you get your head around it, it's really easy to implement for us as clinicians, but to help service users understanding of their own voice and vocal quality too. And it really helps with our high quality information for referrals for ENT and helping screen for that too. So another useful tool in our toolkit.
I think the other thing to consider is that this was fairly cheap to implement. The PRART software is free to download, and although quite complex, once we'd set some procedures, it was really easy for us both to be consistent in our analysis of voice recordings. The voice recording software is also free. You can undertake quite complicated and detailed analysis of pitch, loudness and CPPS ratings for free using free downloadable resources that plug into PRART. There are also commercial software solutions available with more detailed graphs, which we'll see slightly later. But I was able to put all the links for this and guides on the website speechtherapy.co.uk. So if you're interested in implementing these procedures, you can put these into place for a very low cost. And for software, all the software is potentially free.
Lovely. So this is our equipment setup. You can see kindly one of our lovely service users has agreed to be in this photo to show you how we set it up. It's a photo of them reading the rainbow passage. So we have a headset and microphone at a fixed distance from the mouth, an amplifier, and we've got the computer set up there with the microphone and the amplifier adapted into that. Our recording software, so we use Audacity. You can use that for free. On the Mac, Sound Studio, isn't it, Sean? Yeah, Sound Studio as well. Audacity is great, it's free, it does everything you need it to do. You can find sometimes it can be a little bit temperamental, like us all. So Sound Studio, we've got that to use on the Mac as well. But when you're setting this up, you can use Audacity. And then the analysis software, which is PRART that Sean has just mentioned.
So this setup was recommended by Curtis, and there's a link to the video, who's a speech and language pathologist based in the US. And these equipment is fairly easy to set up. Although that's quite a fancy Mac that we wanted in order to do all our work on, it can run on quite old equipment, and we've got old laptops that run it quite happily, that are more than 4 or 5 years old.
Yes, yes.
So this is just a closer image of the condenser microphone kit and amplifier, which plugs in by USB to the back of a standard computer, and then allows us to do those high quality recordings. We save them as WAV or WAV files because they're lossless formats. And we can then produce PDFs of the analysis and be uploaded to the EMIS patient information system once we've done all the analyses and discussion.
And as well, sorry, just to jump on that, Sean, is what's really useful is with this PRART, and once you've had a go and you've got your head around it, it's really quick to use. So now I've been able to use this live in sessions with service users to be able to feedback on their results and give them a visual representation on their voice, and help guide patients into goal setting with our service users as well, and help them give that understanding during the session as well. So going on to quite nicely, this is a graph of PRART looking at pitch of a service user. So I'll make sure I'm in the camera here. It's filled in my chair. Pitch of a service user reading the rainbow passage. Now you can see that this we can give this to the service user in the session, as I've just mentioned, and it gives a really good visual representation for the service user to help them understand their pitch range and their intonation styles. It helps them see their medium pitch, which you can see in the red line going across, and their mean pitch with further information on that as well. And as I said previously, it helps their understanding on what pitch is, what that means for them, and their goals, whichever way they want to go, that's authentic for them.
I think it's really important because a lot of our service users perceive pitch as an absolute goal, and that any variation from that average range was a mistake. And we were saying, look at my pitch, you know, if I'm really excited, I go into a much higher range than my persistent average pitch. And it really helped them to understand that kind of flexibility of vocal use.
Lovely. So here we've got as well another pitch graph looking at sound pressure level, so volume measured in decibels. Now it's really important you can only complete this in person, because if you were doing it online via telehealth, you will be recording the sound pressure level of your speaker of the computer. So this one's for in person only, but this is really useful to help service users have a look and understand their volume, their output as well of their voice. And understand it can be used as an assessment and therapy tool as well. It can also help guide ENT referrals if we're thinking about a low sound pressure level that's consistently low. We want to be able to think, oh, what's going on there? And it can, which is also important as well, to think about our trans feminine service users or trans women who sometimes seem to think that having a low sound pressure level, a low volume, is attributed with that stereotypical cis feminine range that they may be wanting to work towards, where actually we can help use these graphs to then show service users you can use your pitch, you can use your resonance, whatever's authentic for you, at a volume that allows you to communicate in whichever way you want to as well. So a louder volume as well.
Yeah, and I think the kind of crossover points in therapy when we've used it to show people that poor breath support leads to not only a drop in pitch, but also in terms of loudness, and why that might be the case.
Lovely. So moving on to smooth septal peak prominence, or our CPPS. I want you to have a little look on the graph on the right. Sorry, I'm getting myself confused with which way to point over the screen, but have a look on that graph. Now this is of a service users recording of a sustained R vowel. Now what we expect for sustained R is to see one clear band going across, because it's one source of one point of phonation. Now what we can see here is one clear band at the bottom, but then above you've got a slightly fainter band as well. So this can show us that they're about their vocal fold vibration and the jitter and shimmer going on, and there might be multiple sources of contact, for example. So if you now look at the left on the cutoff score, CPPS, we can give you the graph that you can see here. It also gives you a figure. So there's thresholds where between a voice disorder is detected or not, and like maybe needing an ENT referral of 14.45, less than for sustained R, and that's a different value for connected speech too. So you can see here the service user has got a value of 14.35, so is borderline, just underneath. Now, Sean, if you could play, I want you to listen to the voice recording of this service user's vocal quality for sustained R too. Great, thank you. So I hope you could just pick up on those slight perceptual differences there. So this is also a really important tool to help guide your perceptual and other information that you gather from listening to that service user. So as I said, why is this important? Sorry, Sean.
Sorry.
We could go back one slide. Yep. So I've got more to say to you, everybody. Could talk about CPPS all day. But like the AI talk that we had yesterday, what I want you to take away is this is a tool in your toolkit. It is not an absolute. So this is a really sensitive measure, this graph. So I had laryngitis in January last year. You can still see some faint lines on my graph too. So it's not saying if you see more than one line, straight away refer to ENT. Use it as you do with everything as a therapist, as a tool in your holistic assessment and therapy kit as well. Thank you. We can move on.
So CPPS is extremely sensitive and accurate, and a really good objective measure of voice disorder compared and kind of encapsulates jitter and shimmer in a much more understandable single measure. The service users found it really helpful and acceptable, so it really supported their attendance at things like ENT when we had concerns, or if we said this is a borderline case and you really need to focus on your breath support to address that, and then they could see the change in their CPPS rating. They really found that quite motivating. And because it's objective, I think they found it really helpful as a point of discussion during appointments. And the cost is so low. I mean, for the microphone, the small amplifier and the connecting cables, it was only £324, which as a clinical tool has been so valuable for us in the clinical situation.
So finally, what have service users had to say? So this is a quote from a trans feminine service user who recently underwent phono surgery and came back and disclosed this. So we did CPPS to look at their vocal quality, and they said it really helped her to see where she is with her voice and understand her underlying vocal quality there as well by having that visual support. And again, the visuals from PRART also helped to have a look at and understand the need for breath support, pitch control, and also projection as well.
Okay, and I think that takes us to precisely 14 minutes. There we go, thank you.
Thank you so much for that presentation. Now, I think we've got several questions for different people. So I will start with the first one that came in, and that was from somebody called Carol, who's asked Rajan, did you incorporate direct voice work as well? She also apologises because I think her connection wasn't perfect, so if she mentioned it, she wants to apologise for having missed it.
That's fine. Not in this study. We didn't include direct work. We wanted to just see the outcomes of the voice use reduction program, what they would be in isolation. But we do recommend that obviously all vocal hygiene education and tools that promote vocal hygiene itself being used in conjunction with direct voice therapy always.
Absolutely. And Anna has also added, how long did you follow the group of patients for, and how long was their follow-up?
The presentation of the VUR, it was an 8-week program they followed. So actually the whole program is normally 10 weeks, but because none of the participants that we were specifically using presented with acute vocal pathology, the severe stage of VUR is only reserved for vocal pathology. So that's why we took it down to 8 weeks, because it was just the moderate and the low VUR stages that we implemented then for 8 weeks.
Great, thank you. And then I think there's a question for Jo from Shafaq Hassan. I think this is for you. And she's asked, how did you decide 4 or more was cause for concern in your analysis?
So that is a statistical type question, and my colleague Tim Pring did the stats analysis for me. But there was a correlation between a score. I can't remember. I'm going to be honest. I can't remember. If that person would like to contact me, I don't know if there's a way that they can contact me direct.
Yeah, they can.
I'd be very happy. Yeah. Is that okay? Rather than misquote, I'd rather actually look it up properly. Is that okay?
Yeah, of course. I have a quick question actually. How did you choose the 5 symptoms that you selected to kind of identify a problem?
Yeah. So this research was originally what I was doing a voice pedagogy postgraduate certificate, and that's how the research started. It was for that, and so within my cohort there were about 20 of us, and the rest of them were all, a lot of them were singing teachers and all active singers, and I kind of did a little pilot questionnaire, and also somebody who's sung all my life, I was interested in those symptoms. So it was a bit of a kind of, these are the symptoms that I think, and also I checked with them and they made a few tweaks. So those are what we came up with.
That's great, and congratulations on your survey response rate, by the way, because that was very impressive.
The power of social media. Yeah, the power of social media, but I do also think that it showed an interest that actually once people looked at the questionnaire, they were interested enough to carry on and filling it in. Yeah,
that's what you want in research, isn't it? Buy-in from the people that you're researching. So well done. Sean and Alicia, just a quick question from me. I guess, what specific voice disorders do your service users experience if you kind of identify them when you refer them to ENT? What kind of things are picked up?
I mean, it tends to be just basic dysphonia caused by overuse without suitable breath support, because they've tried, as much as we advise service users not to look at social media and attempt things without professional supervision, they do, because they're really feeling dysphoric and want to try and change their voice. So we find that people have really misused their voice and strained their voices. We're aware that because trans people tend to have a slightly higher functional voice problem, I'm also concerned we might miss somebody with an organic problem. So we are quite strict in screening and referring, because we're putting a lot of pressure and demand on service users once they do start our voice groups. So we want to make sure that they really have a really good, strong voice before they start making any changes to their voice.
Yeah, I was just thinking we get just quite a few service users coming back saying they have a hyperfunction of the voice, so that strain and tension, and it's about making sure there's nothing, as you've said, Sean, pathological, anything underlying, then how can we support that with correct therapy techniques and breath support, for example.
And stress levels are incredibly high. You know, we have lots of people with anxiety, so it's unsurprising that they have very high levels of kind of muscular tension around the larynx, which, by doing things like diaphragmatic breathing, relaxation techniques in our groups, we can address if that is the underlying cause. But if it isn't, we're not voice pathology specialists, so we would routinely refer all those service users regardless of the underlying etiology. And because it's non-invasive and quick, we can then just refer to ENT with that advice, although ENT did raise a few eyebrows when we first walked in with CPVS functions, but I was quite pleased to see that a service user with post-COVID that had pseudo-vocal fold involvement, we could clearly show on the graph that we suspected that before, and we often attend ENT appointments with that information. So we're kind of educating ENT as well about those kind of measures that we're using.
That's great, and there's been some really positive comments in the chat about using acoustic measures of voice, and congratulating you both for making it seem accessible and a bit less scary, not just for this patient group, but for any service users really. Rujan, there are a couple of other questions for you. One is, well, both from Claire Campbell, asking, can you tell us more about what the VUR actually consists of? And also, you said that voice rest deconditions the voice. Do you mean it in a good or a bad way? Can you expand? So I don't know if you can see those in the Q&A.
Find that, yes. Okay. Oh goodness. Sorry, I seem like I can't see that. Oh, yeah.
The first question, if you go with the first question, it's what the VUR actually consists of.
Okay, so yes, very briefly, I explained that the VUR is basically allocating to the client a certain amount of voice use in a day, and then also across a week. So in the severe stages, these voice units are obviously quite low, and we try and get voice use to a low stage so that we can try and assist this vocal fold healing process, because the severe stage is obviously targeting vocal pathology, specifically organic pathology. But then we move on to the moderate stage where more voice units are allowed, and it's not specifically targeting organic pathology. And that's why more and more units are then allowed from moderate to then low stages. So I know that's a very broad overview, and I really do recommend, and it's referenced in my slides, the original article from Anita van der Merwe, because she goes and breaks it down step by step how you can practically go and apply these principles for VUR to your practice, you know, and how you allocate the unit specifically to your client. It's actually a session where you sit down with the client and you realize, you ask them how do they use their voice throughout the day, and then go and allocate according to severity, you know, an amount of units to the situation, and then allow them from there what they can use for the day and for the week. And like I said, then you plot the graph for them in those subsequent stages, and more units are allowed. And it obviously gets to a point where it's more normal voice use, because voice rest is challenging to most people, especially in these occupational voice professions. Most of them singers or stage actors are quite expressive and outgoing people, and they want to be able to use their voices even when they are in their downtime. So sometimes they don't allow, you know, sufficient or adequate voice rest times to help them get over a sickness or get over some voice damage that might have occurred due to their occupational voice demands.
Great, thank you. And then the second part of that was
yes,
about voice rest. And do you mean it deconditions the voice in a good or a bad way?
Yes. Okay. So what I was implying there is that was a phrase in literature saying that voice rest, in terms of absolute silence and absolute total voice rest, can decondition the voice as a tool, and we need to be aware of this and use voice rest in this way that we now propose, in terms of in a modified way, not in complete voice rest, because that is now only reserved for post-operative guidelines and laryngeal trauma in cases. But we want to see if we can allow the voice to rest to a certain point where we are not deconditioning it, as well as then, like I said, congruently using direct voice therapy to recondition the voice once we've just allowed it to rest and to heal. I hope that answers your question.
I think it does. There's another couple of questions for Sean and Alicia. What is the evidence that voice disorders are more common in trans versus cis people?
I think that's in one of the references, isn't it?
Yes.
It's, I mean, like a lot of research in trans and non-binary voice, the numbers are quite small, because trying to get ethics clearance with people who are, for obvious reasons, quite reluctant to take part. But there is, I think, one of those references. I can follow that up if they contact me. But yeah, I think it's because of those things that we mentioned, of people as a group trying to change their voice prior to contact with speech and language therapy.
I think as well, sorry, just to jump on that. Now, I'm looking to the back of my brains here, but thinking about the WPATH 8 guidelines, the guidelines for trans healthcare, and in there as well, it is looking at the vocal risks for our trans service users, because they are at higher risk. So it's within the guidelines in WPATH 8, I think, as well.
Yeah, and I think Sean's point earlier about the psychological implications and the things that they're going through from that perspective, we know how much psychology impacts voice in anybody, so it suggests a higher risk, certainly.
I mean, interestingly, we've had someone who was a choir member, yeah, and still, although they were aware that they should be using their voice a certain way, were still taking risks with their voice that they knew they shouldn't. So I think, you know, it was kind of, we were nodding away when we were saying speech therapists, you know, choir users kind of get explanations about why they're experiencing these kind of challenges to their voices when they do get intervention. So yeah, we were thought that people in choirs might have better breath support and therefore less likely to have these difficulties, but it seemed it didn't protect that particular service user.
So I think there's another question for Sean and Alicia. It's quite long. How do you find the links between your services and the SLT services when you need to access their involvement? Do you have any advice for SLTs working in voice when working with trans and non-binary people with organic voice disorders? I'm keen to support the gender affirming therapy approach while acknowledging it's not my main area of expertise. And that's from Harriet.
Well, I'll pass the list because you've been shadowing and going with appointments to people, haven't you?
Yes, so just touching on that first point about ENT and linking up with ENT and other more general SLT services and ourselves, we've actually created links between Manchester Foundation Trust. We've delivered training to support their gender affirming voice therapy within their own services. I've shadowed ENT appointments and let them know about the reasons and clinical rationale for some service users with a high risk for needing ENT first. And also we're going to shadow some joint ENT appointments with our service users as well. Now bear with me, sorry, I want to make sure I'm answering the second part of your question. So any advice for SLTs working in voice and with organic? Yes, so I think, and I'm sure you'll be able to jump in and help me here if need to, but I think our guidance is that work on the organic voice disorder first. That's really important because your VCT, for gender affirming voice therapy, is intensive. It's going to place lots of demands on the voice. If there's underlying pathology going on first, you're going to make that worse. So our advice would be to work on that voice disorder, and you'll be the experts in that there, and still being mindful of this is to work towards, and then again can work towards a gender affirming voice therapy as well. Have you got anything else to add?
Just to say, yeah, we have a few users who have had NHS speech and language therapy for a voice disorder, and then we have been more mindful about using techniques like straw work, you know, easing in warm-ups. We are very careful to have lots of warm-up activities anyway, and it's been wonderful to do in-person groups again post-pandemic, and we've really enjoyed those because we can really see where people are going wrong, which is, I think, much harder on telehealth, which is what we had to do during the pandemic. But I think, you know, I was glad to see, you know, the importance of warm-ups and things like that for all voice work, you know, and I think people take their voices for granted. Even trans people are trying to change, you know, voice clear, throat clearing, you know, not being hydrated. All these, the basic messages are so important when you are, you know, using your voice in any way, shape or form. So I think we've kind of enjoyed getting those messages across.
Just as well, sorry, we'll stop talking in a moment, but the vocal hygiene advice is something that we cover every single appointment, every single session. And again, if we have service users coming through where we know they've had ENT concerns, for example, but they have been cleared by ENT, it's really reiterating that to service users and also keeping a mindful eye. And that's where the computerized voice evaluation comes in really helpful, because you can actually see when you're doing the pitch, say for example you've got the fundamental frequency graph, when they lose their breath support, you will see, sorry, I'm trying to do it backwards to the camera, I can't do that, you'll see like a square kind of drop. So that's really useful to have that visual to show them, look, this is what's happening to your voice, use the breath support and vocal hygiene techniques, etc. Sorry, windy answer, but I hope that's answered the question.
No, that's great. And actually, Jo, just for you thinking about the kind of education, if you could go to sort of all amateur choirs, what advice would you give them as a speech and language therapist and a singer?
Well, I think it is really important for the choir master, choir leader, conductor, whoever, choir director, whatever you want to call him or her, to take responsibility for doing really good choir warm-ups. Unfortunately, in my experience, some of the choir directors come from an instrumental background rather than a singing background, and a lot of them think that singing is warming up, and they almost look on it as a kind of, oh, let's practice that tricky phrase. That's not what a warm-up is. So I think they need to take responsibility for really looking into what is an effective warm-up. You know, the simple form that we used, the vocal health indicators, might be a really useful screening just to make everyone aware. The vocal hygiene that Sean and Alyssa were talking about, absolutely bang on about it every single week. Everyone bring their water, you know, warm up beforehand, cool down afterwards. I could go on. And if we do have time, my memory has slowly caught up, and I can possibly really briefly answer Shafak's question of deciding that 4 or more.
Have like a minute or so.
Okay, it was simply that when we looked at the participants who did have a diagnosis of a voice disorder, and we looked at their scores on those vocal health. They were scoring, I think it was on average 3.7, and therefore we kind of concluded that if they've got a known disorder and they're scoring 3.7, anyone else scoring 4 and above are very likely to also have a problem.
That makes a lot of sense. So I think this is the end of this session. There are a couple of unanswered questions in the Q&A that I haven't caught up with. So Joe, there's one for you if you want to have a look, from Susan Balgani, and there is one for you, Rujan, from Anna. So you might want to get in touch with them to answer in person, if that's okay. Sure. But thank you all for joining. It's been a fantastic session. I've really enjoyed it. And looking